Next online, we have the autism spectrum disorder of the F84.0. For its diagnostic criteria, the criterion A, persistent deficits in social communication and social interaction across multiple contexts as manifested by all of the following, currently or by history. First, deficits in social emotional reciprocity ranging, for example, from abnormal social approach and failure of normal back and forth conversation to reduced sharing of interests, emotions, or affect, to failure to initiate or respond to social interactions. Second, deficits in nonverbal communicative behaviors used for social interaction, ranging, for example, from poorly integrated verbal and nonverbal communication to abnormalities in eye contact and body language, or deficits in understanding and use of gestures to a total lack of facial expressions and nonverbal communication. Third, deficits in developing, maintaining, and understanding relationships ranging, for example, from difficulties adjusting behavior to suit various social contexts, to difficulties in sharing imaginative play or in making friends, to absence of interests in peers. So, criterion A, impairments are pervasive and sustained. In criterion B, restricted repetitive patterns of behavior, interests, or activities as manifested by at least two of the following, currently or by history. So first, stereotyped or repetitive motor movements, use of object or speech, such as simple motor stereotypes, lining up toys or flipping objects. Echolalia, idiosyncratic phrases. Second, insistence on sameness, inflexible adherence to routines or ritualized patterns of behavior or nonverbal behavior, such as extreme distress at small changes, difficulties with transitions, rigid thinking patterns, greeting rituals, need to take same route or eat same food every day. Third one, highly restricted, fixated interests that are abnormal in intensity or focus. Example, strong attachment to or preoccupation with unusual objects, excessive circumscribed or perseverative interests. Fourth one, hyper or hypoactivity to sensory input or unusual interest in sensory aspects of the environment, such as apparent indifference to pain, temperature, adverse response to specific sounds or textures, excessive smelling or touching of objects, visual fascination with lights or movement. So, criterion B, autism spectrum disorder is also defined by restricted, repetitive patterns of behavior, interests, or activities which show a range of manifestations according to age and ability, intervention, and current supports. For the criterion C, symptoms must be present in the early developmental period but may not become fully manifest until social demands exceed limited capacities or may be masked by learning strategies in later life. So special interests may be a source of pleasure and motivation and provide avenues for education and employment later in life. For the criterion D, symptoms cause clinically significant impairment in social, occupational, or other important areas of current functioning. So, criterion D requires that the features must cause clinically significant impairment in social, occupational, or other important areas of current functioning. For the criterion E, these disturbances are not better explained by intellectual developmental disorder or global developmental delay. Intellectual developmental disorder and autism spectrum disorder frequently co-occur. To make comorbid diagnosis of autism spectrum disorder and intellectual developmental disorder, social communication should be below that expected for general developmental level. So criterion E specifies that the social communication deficits are not in line with the individual's developmental level. Impairments exceed difficulties expected on the basis of developmental level. So note that individuals with a well-established DSM-4 diagnosis of autistic disorder, Asperger's disorder, or pervasive developmental disorder not otherwise specified should be given the diagnosis of autism spectrum disorder. Individuals who have marked deficits in social communication but whose symptoms do not otherwise meet criteria for autism spectrum disorder should be evaluated for social pragmatic communication disorder. So, specify current severity based on social communication impairments and restricted repetitive patterns of behavior. So, specify whether it requires very substantial support, or it requires substantial support, or it requires support. So, specify also if with or without accompanying intellectual impairment, with or without accompanying language impairment. Specify if associated with a known genetic or other medical condition or environmental factor, or associated with a neurodevelopmental, mental, or behavioral pattern. Specify also if with catatonia. So for the severity level, for level 1, it requires support both in social communication and in restricted repetitive behaviors. For level 2, it requires substantial support because deficits in social communication are apparent even with supports, and restricted repetitive behaviors appear frequently enough to be obvious and interfere with functioning. Lastly, sa level 3, it requires very substantial support because there are severe deficits in social communication that causes severe impairment in function, and restricted repetitive behaviors markedly interfere with functioning in all spheres. Also, great distress or difficulty changing focus or attention. For the for the recording procedures. So first, note level of support needed for each of the 2 core psychopathological domains. Also specify if with accompanying intellectual impairment or without accompanying intellectual impairment. So language impairment specification should be recorded thereafter. If there is accompanying language impairment, the current level of verbal functioning should be recorded. For genetic or other medical condition or environmental factor or associated with a neurodevelopmental, mental, or behavioral problem are appropriate. Record autism spectrum disorder associated with the name of the condition, disorder, or factor. For example, autism spectrum disorder associated with tuberous sclerosis complex. So this specifier is applied to presentations in which the listed condition or problem is potentially relevant to the clinical care of the individual and do not necessarily indicate that the condition or problem is causally related to the autism spectrum disorder. So if associated naman with neurodevelopmental or mental or behavioral problem, meets criteria for a neurodevelopmental or other mental disorder, both autism spectrum disorder and the other disorder should be diagnosed. If catatonia is present, record separately catatonia associated with autism spectrum disorder. For the specifiers, so first for the specifier with or without accompanying intellectual impairment, separate estimates of verbal and nonverbal skills are necessary. To use the specifier naman with or without accompanying language impairment, the current level of verbal functioning naman ang i-assess and i-describe. Yung specifier naman na associated with a known genetic or other medical condition or environmental factor can be applied when an individual has a known genetic condition, a known medical condition, or a history of environmental exposure in utero to a known teratogen or infection. So this specifier should not be viewed as a synonymous with causation of autism spectrum disorder. So, a condition may be listed as being associated with autism spectrum disorder when it is thought to be potentially clinically relevant or informed care and not because the clinician is asserting a cause. So the specifier naman associated with a neurodevelopmental, mental, or behavioral problem can be applied to indicate problems such as irritability, sleep problems, self-injurious behavior, or developmental regression that contribute to the functional formulation or are a focus of treatment. So additional neurodevelopmental, mental, or behavioral disorder should also be noted as a separate diagnosis. So, sa catatonia naman, catatonia can occur as a comorbid condition with autism spectrum disorder. In addition to classic symptoms of posturing, negativism, mutism, and stupor, an increase or worsening of stereotypy and self-injurious behavior may form part of the symptom complex of catatonia in the setting of autism spectrum disorder, or the associated features. So, many individuals with autism spectrum disorder also have meron din silang intellectual or and language impairment. So, it is common for individuals with autism spectrum disorder to have theory of mind deficits, but these are not necessarily present in all cases. So, executive function deficits are also common, but not specific, as are difficulties with central coherence. So motor deficits also are often present. So self-injury may occur, and disruptive or challenging behaviors are more common in children and adolescents with autism spectrum disorders than other disorders, including intellectual developmental disorder. So symptoms for the development course symptoms are typically recognized during the second year of life, that is age from 12 to 24 months, but may be seen earlier than 12 months if developmental delays are severe, or noted later than 24 months if symptoms are more subtle. So first symptoms of autism spectrum disorder frequently involve delayed language development, often accompanied by lack of social interest or unusual social interactions, such as pulling individuals by the hand without any attempt to look at them, or odd play patterns such as carrying toys around but hindi naman nila laruan, and unusual communication patterns such as alam nila yung alphabet but they do not respond to their own name. So deafness may also be suspected but is typically ruled out. During the second year, odd and repetitive behaviors and the absence of typical play become more apparent, since many typically developing young children have strong preferences and enjoy repetition, such as eating the same food, watching the same video multiple times. So, distinguishing these restricted and repetitive behaviors that are diagnostic of autism spectrum disorder can be difficult in preschoolers. So, the clinical distinction is based on the type, frequency, and intensity of the behavior. So, autism spectrum disorder is not a degenerative disorder, and it is typically for learning and compensation to continue throughout life. So, relatively little, but sa DSM-5 sabi nun, anything. So, relatively little is known about old age in autism spectrum disorder, but higher rates of co-occurring medical conditions have been documented in the literature. For the risk and prognosis factors, so, for the environmental, a variety of risk factors for neurodevelopmental disorders such as advanced parental age, extreme prematurity, or in outer exposure to certain drugs or teratogens like valproic acid may broadly contribute to the risk of autism spectrum disorder. For the genetic and physiological, heritability estimates for autism spectrum disorder have ranged from 37% to higher than 90% based on twin concordance rates. And the more recent 5-country cohort estimated heritability at 80%. Currently, as many as 15% of cases of autism spectrum disorder appear to be associated with a known genetic mutation. For the culture-related diagnostic issues, so culture influences the perception of autistic behaviors, the perceived salience of some behaviors over others, and the expectations for child behavior and parenting practices. for the sex and gender-related diagnostic issues. So, autism spectrum disorder is diagnosed 3 to 4 times more often in males than in females. And on average, age at diagnosis is later in females. So, in comparison with males with autism spectrum disorder, females may have better reciprocal conversation and be more likely to share interests, to integrate verbal and nonverbal behavior, and to modify their behavior by situation, despite having similar social understanding difficulties as males. So, repetitive behaviors may be somewhat less evident in females than in males. On average, and special interest may have a more social or normative focus while remaining unusual in their intensity. So, association with suicidal thoughts or behavior. So, children with autism spectrum disorder who had impaired social communication, meron silang higher risk ng self-harm with suicidal intent, suicidal thoughts, and suicide plans by the age of 16 years as compared with those na walang impaired social communication. For the functional consequences, in young children with autism spectrum disorder, lack of social and communication abilities may hamper learning. In the home, insistence on routines and aversion to change as well as sensory sensitivities may interfere with eating and sleeping and make routine care, example, haircuts, dental work, extremely difficult. So adaptive skills are typically below measured IQ. So, extreme difficulties in planning, organization, and coping with change negatively impact academic achievement even for students with above average intelligence. And during adulthood, these individuals may have difficulties establishing independence because of continued rigidity and difficulty with novelty. So, co-occurring intellectual developmental disorder, epilepsy, mental disorders, and chronic medical conditions may be associated with a higher risk of premature mortality for individuals with autism spectrum disorder. So, deaths from injury and poisoning are higher than for the general population as are deaths from suicide. So, drowning, pagkalunod, is the leading cause of accidental death in children with autism spectrum disorder. For the differential diagnosis, for the ADHD, the developmental course and absence of restricted repetitive behavior and unusual interest in the ADHD help in differentiating the two conditions. So, a concurrent diagnosis of ADHD should be considered when attention difficulties or hyperactivity exceeds the typically seen in individuals or comparable mental age. And ADHD is one of the most common comorbidities naman ng autism spectrum disorder. So, intellectual developmental disorder without autism spectrum disorder. So, a diagnosis of autism spectrum disorder in an individual with intellectual developmental disorder is appropriate when social communication and interaction are significantly impaired relative to the developmental level of the individual's nonverbal skills. So, in contrast, intellectual developmental disorder is the appropriate diagnosis pag walang apparent discrepancy between the level ng social communication skills and other intellectual skills. For the language disorders, a social pragmatic communication disorder. When an individual shows impairment in social communication and social interactions but does not show restricted and repetitive behavior or interests, criteria for social pragmatic communication disorder instead of autism spectrum disorder may be met. For the selective mutism. In selective mutism, early development is not typically disturbed. The affected child usually exhibits appropriate communication skills in certain contexts and settings. So, even in settings where the child is mute, social reciprocity is not impaired or nor are restricted or repetitive patterns of behavior present. Next, stereotypic movement disorder. So, motor stereotypies are among the diagnostic characteristics of autism spectrum disorder. So, an additional diagnosis of stereotypic movement disorder is not given when such repetitive behaviors are better explained by the presence of autism spectrum disorder. However, when stereotypies cause self-injury and become focus na ng treatment, both diagnoses may be appropriate. For the Rett syndrome, so, disruption of social interaction may be observed during the regressive phase of Rett syndrome. Thus, a substantial proportion of affected young girls may have a presentation that meets diagnostic criteria for autism spectrum disorder. For the symptoms associated with anxiety disorders, the overlap of anxiety symptoms with the core symptoms of autism spectrum disorder can make the classification of anxiety symptoms in autism spectrum disorder challenging. For the obsessive compulsive disorder, repetitive behavior is a defining feature of both obsessive compulsive disorder and autism spectrum disorder. In both conditions, repetitive behaviors are considered to be inappropriate or odd. In obsessive compulsive disorder, intrusive thoughts are often related to contamination, organization, or sexual or religious themes. For schizophrenia, autism spectrum disorder and schizophrenia can co-occur, and both should be diagnosed when criteria are met. For personality disorders, the early developmental course of autism spectrum disorder is most helpful in differentiating it from personality disorders. For comorbidity, autism spectrum disorder is frequently associated with intellectual developmental disorder and language disorder. Our specific learning difficulties are common, as is developmental coordination disorder. Psychiatric comorbidities also co-occur in autism spectrum disorder. About 70% of individuals with autism spectrum disorder may have one comorbid mental disorder, and 40% may have two or more comorbid mental disorders. Medical conditions commonly associated with autism spectrum disorder include epilepsy and constipation.